am Dr. Brajmohan Singh, working as Director, Department of Cardiothoracic Surgery, SCG Group of Hospitals, Gujarat.
Today I am going to talk about latest update in hypertension. Well, as per World Health Organization, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributed to cardiovascular disease, which affects 45% of people in the 40 to 69 age group. Hypertension or increased blood pressure is among the most important risk factor for cardiovascular disease. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and follow-up. Coming to the Indian picture, in India, the prevalence has gone up over 30 years to 38% in men and 32% in women from 20. Despite that, nearly half of the people, or 51% of the men and 41% of women with hypertension, are unaware of the condition. Additionally, over 62% of the men and 53% of the women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 in 5 in men and 1 in 4 in women with hypertension worldwide. Now, International Society of Hypertension, ISH, has released ISH 2020 Global Hypertension Practice Guideline. The inclusion of optimal and essential treatment paradigms attempts to address the issue that in resource-poor settings, optimal care refers to evidence-based standard of care, and where essential standards refer to minimum standards of care to allow specifications of essential standards of care for low resource setting. The American Heart Association and American College of Cardiology has released a scientific statement in 2021 offering new guidelines for management of stage 1 hypertension among patients with low risk of cardiovascular disease. Among low risk cardiovascular disease adults with stage 1 hypertension, blood pressure between 130 and 139 millimeter of mercury systolic and 80 and 89 millimeter diastolic. Management starts with non-pharmacological therapy. If blood pressure remains uncontrolled for 3 to 6 months, then drugs are started. Acute respiratory distress syndrome, ARDS, is a potentially fatal condition involving lung damage, and experts often associated with severe COVID-19 infection. A recent study which appears in the Journal of the American College of Cardiology reports that metoprolol, that's a beta blocker, can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. Lowering systolic blood pressure targets down to 110 to less than 130 millimeter of mercury range substantially reduced cardiovascular adverse events in step randomized trial, affirming the sprint finding for an older Chinese population. Among some 8,500 patients aged 60 to 80 in China, the intensive target trimmed 26% of the composite CV risk findings from now a second major trial supporting a lower target could unite the guidelines, which even among US professional societies range from the threshold of 130 to 150 millimeter of mercury. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European guideline on the management of arterial hypertension recommend that the diagnosis of hypertension should not be dependent on office BP measurement, but also an out-of-office measurement such as ambulatory blood pressure monitoring or home blood pressure monitoring. 24-hour and nighttime BP measurements are associated with greater risks of mortality and a composite cardiovascular outcome. Thus, they may be considered as the most relevant measurements for estimating cardiovascular risk. For every 20 by 10 millimeter of mercury increment of BP measured at night, the risk of mortality increased by 23% and risk of cardiovascular events by 36%. Most patients with hypertension require lifelong medical therapy to achieve optimal BP control. 2018 European guideline equally recommends 5 classes of antihypertensive drugs. Considering high non-adherence treatment, the importance of combination treatment is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guidelines recommend, especially in the context of lower BP targets, to start antihypertensive therapy with an initial dual fixed dose combination of ACE inhibitor or angiotensin receptor blocker with a calcium channel blocker or diuretic. Since early July 2018, products containing valsartan have been recalled worldwide. The reason is the detection of a known carcinogen, namely NDMA, which can be found in candesartan, irbesartan, losartan, olmesartan, valsartan. NDMA has been classified by the WHO International Agency for Research on Cancer to be carcinogenic in humans. If 1 lakh patients would have received NDMA contaminated valsartan from Zhejiang, Huai, which is the manufacturing site where the highest level of contaminants were found, every day for 6 years in the highest dose, it could result in 22 additional liver cancer over the lifetime of these patients. The presence of NDMA in this drug could lead to 8 additional cancer cases in 1 lakh patients if they had taken the highest daily dose over 4 years. Valsartan recall accompanied by significant increase in the rate of emergency department visits plus 6%. The HYGEA study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoints, that is including deaths. The HYGEA chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension therapy exerts a favorable CVDs reduction. The largest study included a total of 19,084 hypertensive patients. During an average follow-up of 6.3 years, 1,752 participants experienced the primary CV outcome. An ambulatory BP measurement was performed for 48 hours to collect data on how BP differed during sleep. The RR reduction for CV events was significantly improved treatment when compared with awakening treatment. Thank you.